Dear students, I welcome all of you to this INI-CET May 2024 exam Dermatology questions discussion. I'm Dr. Malcolm, your faculty of Dermatology at Marrow. So in this exam, the following topics were covered. 2 questions from Basics in Dermatology, 1 question from Hansen's, 1 from Pigmentary Disease, 1 from Sexually Transmitted Infections, and few overlap topics. Let's take up the 2 questions from Basics in Dermatology. Question number 1. Match the following with various investigations and diseases. In the investigations, what are listed include patch test, slit skin smear, biopsy, potassium hydroxide mount, which are to be matched with lupus vulgaris, tinea corporis, leprosy, and contact dermatitis. Let's first look at patch test, which is used in the diagnosis of allergic contact dermatitis. So patch test is used in the diagnosis of allergic contact dermatitis. Very important to note that allergic contact dermatitis is an example for type 4 hypersensitivity reaction. The test to detect allergic contact dermatitis, patch test, is also an example for type 4 hypersensitivity reaction. So what we do here, students, is these allergens are applied in the form of patches on the back, and then we look for a delayed type of hypersensitivity response. So if the question comes in the exam, patch test is read at or usually read at, our answer will be 48 hours. If the question is reframed as best reading of patch test, we double the time and we go for 96 hours. The next investigation is slit skin smear. Now this investigation is used in the demonstration of M. leprae. So this investigation basically demonstrates M. leprae, so that once we demonstrate M. leprae, we try to calculate the bacteriological index and morphological index. The third investigation here is skin biopsy. Now, skin biopsy is an investigation which is done wherein we try to study the histopathology of a disease. And usually what we use in our OPD is a punch biopsy. We use a punch by which we obtain full thickness of the skin so that we look at the histopathology of the disease. And in the given options, lupus vulgaris is a type of cutaneous tuberculosis. And as we know that tuberculosis is a granulomatous disease, so what we expect here is to see dermal granulomas. Dermal granulomas, and the best investigation to look at this would be a skin biopsy. Lastly, potassium hydroxide mount. So this is generally used in fungal infections like pityriasis versicolor, wherein we're looking for the characteristic spaghetti and meatball appearance. Spaghetti and meatball appearance. This is basically the short hyphae, which is compared to spaghetti, and the round spores, which are compared to meatballs. In chromoblastomycosis, which is produced by pigmented fungi, we get brown, round, thick-walled bodies, which are medlar bodies, also known as sclerotic bodies, also known as copper penny bodies. So these are the findings that we see in the various diseases. And then tinea corporis, what do we get is refractile branching hyphae. Refractile branching hyphae. So we carefully see these are the refractile branching hyphae which are seen in tinea corporis. So the correct match for this would be patch test matches with contact dermatitis, slit skin smear with leprosy, biopsy would be lupus vulgaris, potassium hydroxide mount would be tinea corporis. So the correct match would be option number B, which is A4, B3, C1, and DP. Second question. Which of the following is not associated with annular lesions? A. Tinea corporis, B. Porokeratosis, C. Urticaria, D. Pityriasis rosea. Now, what do we mean by an annular lesion? An annular lesion is also referred to as a ring-shaped lesion. Like this, as we can see in the picture here. When you're talking about ring-shaped lesion, what we need to remember, students, is the periphery of the lesion is the one which is active. And out of the given options, tinea corporis, porokeratosis, pityriasis rosea all can have annular or ring-shaped lesions. The correct answer for this question is urticaria. Now, urticaria is a disease which is characterized by wheals. What is urticaria as a disease? It nothing but represents dermal edema. So here what do we see is we see pruritic elevated transient plaques. So these are pruritic, they're elevated, transient, they come and go. That's what is an urticarial wheal. Porokeratosis was an option this time in the exam, which has been first time asked. So what is porokeratosis? It is a disorder of keratinization. Porokeratosis is a disorder of keratinization. What do we find here is we get annular plaques. So this is point number one. And you have an elevated keratotic rim. Find a elevated keratotic rim which forms the annulus. Next, we move on to the question from Hansen's disease. Which of the following anti-leprosy drug produces skin hyperpigmentation? A. Rifampicin, B. Dapsone, C. Clofazimine, and D. Ofloxacin. Now, what is the side effect of rifampicin, students? Please remember, number one is hepatotoxic drug. Number two, reddish discoloration of body secretions like urine. Reddish discoloration of body secretions like urine. So please remember, many students incorrectly mark this answer as rifampicin. Rifampicin doesn't produce skin discoloration, it produces body secretion discoloration. Dapsone. What are the important side effects of Dapsone? Number one, we have hematologic side effects. So when I say hematological side effects, we can have agranulocytosis. We can also have hemolytic anemia. Hemolytic anemia. Hepatitis is also one side effect of Dapsone. And lastly, we can have hypersensitivity reactions. So three important side effects of Dapsone to summarize would be number one, hematologic, number two, hepatitis, number three, hypersensitivity reaction. The correct answer for this question is C, clofazimine. Now, what is clofazimine and its important side effects? Number one is hyperpigmentation. So the three side effects of clofazimine is important to remember for exam. Number one is hyperpigmentation. Number two is ichthyosis. So students, can you tell me what is the meaning of the word ichthy? Now, ichthy means fish-like scales. So ichthyosis is a condition characterized by fish-like scales, and clofazimine is an important drug which produces ichthyosis. So it's a cause of acquired or drug-induced ichthyosis. The last important side effect of clofazimine would be GI disturbance. Now, what exactly happens to clofazimine is the color, which is going to be brownish red hyperpigmentation here. And the mechanism is due to the deposition of the intracellular drug-derived crystal. So please remember, students, the reason for all this is clofazimine is a dye and it tends to deposit within the skin. We move on to the next topic of pigmented disease. The question here is, which type of vitiligo is initially progressive and then becomes stable and non-progressive? A. Focal, B. Segmental, C. Mixed, and D. Acrofacial vitiligo. The correct answer for this question is B. Segmental vitiligo. Now, please remember, students, focal vitiligo is basically characterized by solitary, isolated, depigmented lesion. So generally, this is a solitary, isolated, depigmented lesion. When I'm talking about segmental vitiligo, what is a segmental lesion in dermatology? Now, segmental lesion is the one which involves structures supplied by single specific spinal nerve. So the structures which are supplied by a single specific spinal nerve is referred to as segmental. Now, this is a segmental vitiligo which is following a specific spinal nerve distribution. Please remember, students, that segmental vitiligo is very unique, that the onset is during early childhood. This is point number one. When we look at the evolution of this disease, what is going to happen? Initially, it shows a rapid progression. However, later on, it stabilizes. So this course was asked in the MCQ. Further, we have to remember, we get depigmented chalky white macules, which are segmental in distribution. Leukotrichia may be present. So very important to remember that leukotrichia may be present. So what is leukotrichia, students? So presence of white hair. That means the process of the destruction of the melanocyte has not only involved the skin, it has also progressed to involve the hair follicle. And the treatment for segmental vitiligo is predominantly surgical. So surgical modalities are the best modalities to treat well-established segmental vitiligo. Next, we move on to the question from sexually transmitted infections. Drug resistance is associated with which of the following STDs? Option A, gonorrhea, option B, syphilis, option C, gonorrhea, and option D, chancroid. The correct answer for this question is gonorrhea, which is option number C. Now, when we look at the entire prevalence and the incidence of gonorrhea worldwide, there is increased reporting of antimicrobial resistance to gonorrhea. Now, let us look at the different reasons which are associated with resistance worldwide. Number one, due to unrestricted access to antimicrobials. Number two, many times in many countries, there may be inappropriate selection or overusage of the antibiotics. Third is quality of antibiotics may be poor. Fourthly, the organism Neisseria gonorrhoeae is known for genetic mutations. And lastly, in terms of gonorrhea, we can also have oropharyngeal gonorrhea and rectal gonorrhea. That means infections are known to occur outside the genital tract, especially in men who have sex with men. So these are different factors which contribute to drug resistance in gonorrhea. Now, why Neisseria gonorrhoeae is regarded as a superbug or a multi-drug resistant organism is the number of antibiotics to which it is resistant. Initially, for this condition, penicillin was considered as the drug of choice, but now, however, this Neisseria gonorrhoeae organism is showing resistance to penicillin, quinolones like ciprofloxacin, macrolides like azithromycin, sulfonamides, tetracyclines, and the drug which is currently considered as the drug of choice for Neisseria gonorrhea is ceftriaxone, and now few reports are there which show resistance to even cephalosporins like ceftriaxone. That is why this is a problem which is very important when you treat patients with sexually transmitted infections like gonorrhea. The correct answer for this question, as I mentioned to you, is gonorrhea. However, we should just revise the treatments for the other STIs as well. For gonorrhea, the best drug would be tablet azithromycin, 1 gram per week into 3 weeks and till ulcer heals. So we know gonorrhea is characterized by that beefy red granulation tissue which bleeds on touch. So this would require a little longer duration of azithromycin. For syphilis, we know always, especially we're talking about primary syphilis, the treatment is going to be injection benzathine penicillin, 2.4 million units, deep IM after a test dose. So that's a single dose for primary syphilis. For chancroid, we give tablet azithromycin, 1 gram stat. Now let's look at some additional points as a part of overlap with other subjects. The drug associated with UTI, which was asked in this year's exam and previously, genital candidiasis, is dapagliflozin. Now please remember this drug belongs to SGLT2 inhibitor, which results in increased glucose which is getting excreted to the urine. So genital candidiasis can also be associated with this drug, which is dapagliflozin. Next, there was another question which was pertaining to a history of a child with vesicles on the trunk and meningitis, and the mother who had history of genital ulcers, with even a point being mentioned that the Zank smear showed multinucleated giant cells. So we know that multinucleated giant cells can be seen in HSV1, 2, and varicella zoster virus. With the mother having history of probably painful genital ulcers, we can consider the diagnosis of the organism as HSV2, as genital herpes, which is now presented in the child with vesicles over the trunk. Next, which disease is associated with decreased corneal sensation? This is an ophthalmology overlap question. The correct answer for this question is leprosy. This question has previously also been asked as a disease which is associated with orbicularis oculi paralysis, wherein there would be associated lag of thalamus. So this question has repeated twice in the INI-CET exam with the answer being leprosy. With this, we conclude our discussion of the dermatology questions, wishing all of you all the very best for the upcoming exam. Thank you.